So next up, we're having a lecture by the MD of the Cardio Care Hospital, a great teacher, very amiable leader. His name is Dr. Olalekan. Please put your hands together for him.
I hope we're enjoying ourselves. So this morning, we have a very short time to talk about an important topic that is second to chest pain when it comes to the number of patients you see during our clinical hours. So most common complaint we encounter is number one, chest pain. Then after chest pain, most people will come to you complaining of whatever they describe or whatever they understand to be palpitation. So this morning we'll be quickly going through how we evaluate our patients with palpitation. And this is where what Prof talked about yesterday must come into play. History and physical examination. If you can take a good history and examine your patients very well, about 70% of this case you will solve, even without doing ECG, echo, and for about 30%, by the time you do this extra investigation, you are able to place them appropriately where they belong. So we want to see the different way people define palpitation, underlying etiology, and how we assess and manage our patients. So we have this 42-year-old man that came with 6-month history of what is described as skipping of his heartbeats, then that he usually experiences this feeling that the heart is sinking. And he's been taking treatment for what was described as a peptic ulcer for a year, and apart from that, he was essentially fine, no other complaint. And during the history, he's been having a lot of stress at work, and his mom, as at that time, was also on treatment for stage 4 breast CA. Examination finding was normal. So, what do we think this patient has? Do we think this is anxiety? Do we think we need to stop at this point, or do we need to do further investigation, or we should just send him to a psychiatrist for further evaluation? And before we go ahead, I want us to take note of this. If this is the only thing we can take away from this presentation, I think it's enough that all palpitations are not arrhythmias. And there are many arrhythmias that will not present with palpitation. So the fact that someone is complaining of, oh, my heart is skipping, is doing BBB, does not mean there's a heart problem. So that's why palpitation does not necessarily mean a heart disease. And also, the degree of palpitation has been, I couldn't sleep for the past 2 days, it's been doing like this, does not equate to a very severe heart disease. So we have to be gentle and take a careful, detailed history to be able to piece out and select the one that are serious cardiac condition and the ones that are not. So it's a very common symptoms, and like I said, it's a second to chest pain when you run a cardiology clinic. It can be intermittent, it can be sustained. And there are different descriptions. From increased awareness of a normal heartbeat, some people describe what they feel as rapid pulsation. Some people talk about having like fluttering or butterfly feeling on the chest. Some people talk about feeling a very heavy thump in the chest, pounding sensation. Some people even describe it as discomfort, uncomfortability. So there are different words that people use to describe what they think is palpitation. But commonly, what we describe as palpitation is uncomfortable awareness of your own heartbeat. So for some people, what they think is palpitation is just increase awareness of their normal heartbeat. And like I used to tell my patients, if the environment is quiet, you are lying on your left side, you can hear your heartbeat, which is normal. But for some people, that is why they will come to the hospital. So you need to explain and reassure them. And it may not be more than that. Then, so like I said, after chest pain is the commonest, because most people will confuse both shortness of breath and palpitation together most of the time. And from a study that was done in 1996, 43%, like less than 50%, is due to a cardiac cause, while others are either due to psychiatric causes, idiopathic causes, and miscellaneous, where we have drugs and other conditions. So, like I said, palpitation could just be due to a change in heart rate. So sometimes, maybe after exercise, anxiety, you can have increase in heart rate, and that is what some people will perceive as palpitation. And also you can have bradyarrhythmia, or reduction in the heart rate. And it could also be due to alteration in the rhythm of the heart. So maybe in patients with atrial fibrillation, where you have disorganized beating from the atrium, that can also be the reason why someone can have palpitation. And like I said, subjective assessment, normal heart rate, but due to one reason or the other, anxiety, somatization, you are perceiving what is normal as being abnormal. And in that case, you need to sit down, talk to the patient, and convince this is a bit difficult to do. And maybe because of other reason, exercise, some hyperhemodynamic states, hyperthyroidism, you can have like increased augmentation of the normal contraction, and that is felt as more forceful heartbeats by the patient. So if we look at that less than 50% that I said is due to cardiac causes, most of them, about more than half of that cardiac cause is mainly as a result of one rhythm abnormality or the other, whether the heart rate is too fast or the heart rate is too slow, while like 1/3 is due to a structural heart disease. And this is why it is important to take your history very well. We'll quickly mention some things that will raise your suspicion, that let me press further to check whether this is just due to anxiety or this is due to an underlying cardiac problem. And we should note that someone can have anxiety and also a cardiac pathology at the same time. So we will need to be patient in taking this history and looking at this group of patients. So these are some of the things you get in your history that will raise your suspicion that, okay, there may be an underlying heart pathology. Male, description of the palpitation as irregular, because when you are taking a history, when someone is telling you, okay, I have palpitation, the first question is, describe what you feel. Or can you tap out the beat? You ask them to tap on the table. So if somebody is doing, you know most likely that is a normal heart. But if somebody is doing, you know there's something there. So you start from something like that. So description of an irregular heartbeat, background history of heart disease. Someone came to you, while I was young, I had a hole in the heart, I did a surgery, I did this, and now coming out, you know there's a substrate likely, and you need to. Then if the duration of the palpitation is longer than 5 minutes, so these are the points. So the more you have, the higher the chance of the patient having a cardiac pathology. And this is just listing different things you can have in terms of rhythm disorder and structural heart disorder. So patients with hypertension, patients with hypertrophic cardiomyopathy, mitral valve prolapse, even severe hypertension with changes in the heart, hypertrophy, dilatation, those are structural diseases that can cause palpitation, and the different readings, some of them we will see when we're talking about ECG later today. Then psychiatric causes, very important. Panic attack, anxiety, depression, a lot of the, and for this group of patients, it's common in women, younger age group, childbearing age, and they have other non-specific symptoms associated with it, something moving, crawling from here to here, I cannot sleep. And sometimes after thorough history, you may be able to get the stressor. We saw a patient that anytime, when she came to us, she was having palpitation. She went to stay with a friend for a week. By the time she came for follow-up, there was no palpitation. By the time she went home to meet the husband, she came back with palpitation again. So putting one and one together, you know where the palpitation is coming from. So she asked us to write a report that she should not go home for some week due to I said that is not medical, that you may need to meet some other people for that. So patient with hyperkinetic states, fever, anemia, hyperthyroidism, all those people, they can have augmentation of the contraction of the heart, and they can have palpitation. And there are drugs which we should note. A patient on bronchodilators, so it may be the drug that is causing that, digoxin, other over-the-counter drug, and recreational drugs. We should not forget about that. We're in Abuja. We see a lot of guests with this. One of the ECG I will show was for a lady that came in middle of the night. I think it was Dr. Amina that saw. And the heart rate was about 160, 170. And all we did was carotid massage, sinus, and the heart rate came down to around 120. We gave beta blocker, and within like 1 hour 45 minutes, she was fighting to go home. She actually died that same morning because she was now fine, but she came from somewhere only God knows what was mixed together. And that's why I said, repeating again, panic and anxiety disorder and cardiac arrhythmia, they are not mutually exclusive. They can occur together, and we should check properly. So that patient was reassured, and it was assumed it was anxiety. But a month later, he had a syncopal attack while at work. No past history, no post-ictal sleep. The eyewitness, there was no jerky movement, and he came back to the hospital. So, and looking at this, what do we think will be the most appropriate step to take at this time? Because, like I said, initially it was just assumed that this is anxiety, and the patient came back a month later having a syncopal attack. So at this point, if ECG had not been done before, a rest ECG must be done. Then after that, you want to look at this heart for a longer period. So you do the ECG over a prolonged period. So an Holter ECG must be done 24, 48 hours to see what the background reading look like, then other things depending on others' findings. So this was the ECG that was done for him. And at least you can see that even if you don't know anything about ECG, you can see some fine one, and you can see some that look as if there's something that is unusual from normal. So you can see this one, and you can see this one, that they are not the same thing, just on the rest ECG. So, and that's why the main aim of evaluation is to make sure that there is no life-threatening arrhythmia going on in the back. That's the main thing you want to do. And repeating again, all palpitation are not arrhythmias, and many arrhythmias do not palpitate. And if we look at the second presentation, when he had the syncopal attack, there was no palpitation, and that was the ECG. And I'm sure for him to have been let go the first time, the ECG might actually have been normal, because most of these patients, by the time they come, the event had passed. So by the time you do your ECG, you will most likely not see anything. So that is where taking a good history and doing your examination properly is very important. So you want to ask them to describe the palpitation, mode of onset, termination, if there are precipitants, associated symptoms, whether vagal maneuver helps to bring it down, and family history. So, like we said, palpitation, middle-aged women, they are most likely associated with psychiatric issue. But very young, then you should know there is most likely an underlying heart condition. Then, palpitation with associated symptoms, syncopal attack, lightheadedness, you should know that is showing you that there's some form of cerebral hyperperfusion. You have to look at that patient very well. So after physiologic activity, exercise, you know that is most likely physiologic. Then I talked about onset. So those ones starting abruptly and ending abruptly, most likely these are arrhythmia from the atrial area. And those with gradual onset, gradual termination, you are talking of most likely sinus tachycardia. The ones that are worse at night, think of atrial fibrillation, some benign ectopic beats. So this is the lady I talked about. The first, on the other side, when she came in, that was when the ECG was done. It was at least about 150, 160. At this point, this was after the vagal maneuver. You can see 112. And within the next few hours, the thing was down to around 80, 90, and she jumped off our bed. So, like I said, different description, like butterfly, flip-flopping. So, those one can be sinus tachycardia with fluttering, but you can have some people describing a heavy beat. That is more likely to be due to a premature ventricular complex, because after the premature ventricular complex, you have a period of pause where the heart gets filled and the next contraction is very forceful. So you asking the patient to describe may help you to narrow down the possibility that you have. So all this we see in our slide is just describing most of the thing I talked about. And palpitation that is felt along the neck is telling us about some specific arrhythmia, atrioventricular, nodal reentrant, tachycardia. So, and associated symptoms. Once you have any of these, please, you need to send the patient to a specialist. Syncope, dyspnea, chest pain, please, that person needs a specialist review. Don't just assume it is anxiety at this point, because you may be dealing with, like I said, reduced cerebral perfusion, myocardial infarction, associated heart failure, some valvular heart diseases. Please, you need to send the patient for review. Excessive urination because of the release of some natriuretic peptide due to all those abnormal contraction. So you should ask your patient about that. Patient bleeding, they can have anemia, they can have tachycardia, which can be perceived as palpitation. Then features of thyrotoxicosis. So you will see that taking a history from a patient with palpitation starts from the so-called NASOMAT that we were taught. Age, sex, occupation, marital status. Like you said, marital status now becomes a risk factor for palpitation. So any past history of heart disease, family history of heart disease. So someone like the patient that was presented yesterday, family history with sudden cardiac death, and the person is presenting with palpitation. Please check that person well. We know about Brugada syndrome, other channelopathy that can cause sudden cardiac death, and many of them, the only thing sometimes they may present with is with palpitation, and when you do your ECG, you see all this long QT syndrome and whatever. That may be the only clue that may allow you. There was somebody that came to the hospital, brother died, and just came to check, and by the time the echo was done, it was hypertrophic cardiomyopathy. fully fit, nothing, no complaints. So you do your examination. So that is why you must touch your patient. You must touch no matter how good the technology is, you must touch your patient. Like I said, many people may not have palpitation, and by touching, checking the pulse, looking at the reading, you feel a lot of things: bradycardia, tachycardia, bounding pulse, irregular pulse, with what they can represent stated there. So we must check our patients. Anemia, check for pallor, check the pulse, count the rate, count the rhythm. Do your basic examination and you'll be able to pick some of these findings. So, and by the time you start getting findings, murmur, raised JVP, extrasound S3, S4, you will know that this is not just anxiety. This is most likely not going to be a benign form of palpitation, and the patient needs to go for further testing. So, and like I said, it is a must. A rest ECG, 12-lead ECG must be done, which is going to show you a lot of things. What the reading looks like, any associated pathology, you'll see it there. Then, now depending on the frequency of the symptoms, now it's going to determine what you're going to do for the longer ECG monitoring. If it's a symptom that occurs frequently, every day or every other day, your Holter 24 to 48 hours can be done, which is readily available. And for events that occurs highly infrequent, you can now start talking about event recorder, which can be carried for weeks, or implantable loop recorder, which can be carried for months. If you go to the back, you will see a small implantable loop recorder there. I think Abbott's stand is there, very tiny, which can be put under the skin and can be there for several months. And any stuff there can even be transmitted to the doctor via your phone. Even before the patient gets to the hospital, the doctor gets to see it, knows what is happening. And so with this, you'll be able to see what is happening in the heart and you'll be able to intervene. And you will need to do other tests depending on other things. If the patient is pale, you do your full blood count, check the electrolytes, check for other things, thyroid function tests, to make sure that any other substrate is taken care of. So as a principle, anybody coming into our hospital with palpitation, we do an ECG, we do electrolytes, calcium, magnesium. You will do a thyroid function test. That is basic, and we'll look at it before we start moving on. Then, based on other findings, echo and every other thing can now come into play. So you can see right from irregular beats, presence of Q waves, delta waves that will mean different things. But by the time we look at ECG, we'll understand some of this thing more. So this is a picture of an Holter which you carry for 24, 48 hours to record the activities of the heart, and you can then analyze. This is a patient represented 2022 Nigerian Cardiac Society. A 36-year-old Caucasian that came. She collapsed a day before presentation in the toilet, just like a minute, and she stood up, nothing, went to the office clinic, and the first ECG that was done, this is the one here, showed just bradycardia and that poor RV progression from V1 to, I think, almost V4, but no other thing, no background medical condition. And by the time she got to us, it was still bradycardia during examination, and we put her on a 24 hours Holter ECG, and we started saying different things. The one under are still reading from that same patient that was with the ECG above. So we just started seeing different different pattern, supraventricular tachycardia, bradycardia, sinus rhythm, PVCs of different. So at the end of the day, it was his sinus node dysfunction that he had. So the sinus node was just doing, so sometimes it will give normal sinus, sometimes it will be bradycardia, sometimes it will be very high rhythm, disrupting blood flow to her brain, and she was scheduled to do a dual chamber pacemaker, but she decided to go back to her country to have that done. So this is a picture of an Holter ECG. Then these are others. The smallest one is the one that I said you can see at the stand at your back, so that you see how tiny it looks, and it's just placed under the skin and can record all the activity for you, and can be sent to the doctor even before the patient gets to the hospital. So what do we do? Next slide. I don't think it's going again. So take your history, perform physical examination, get a 12-lead ECG, and like I said, do your other associated blood tests, do your Holter ECG. If there is indication for echo in the presence of a structural disease, then you do your echo. So if you find a structural disease, then that patient should go to the specialist. If your Holter gives you some positive reading, that patient should go. So number 4, 5, 6, 7 can only be done at the specialist level. But 4A, if all those are normal, if you identify any extracardiac causes, anemia, fever, those can be treated. If there are anxiety, psychiatric issue, you can bring in your mental health units and you do that. And for those with malignant arrhythmia that we will consider for device therapy, those ones must come. People with hypertrophic cardiomyopathy, with previous cardiac arrest and all those ones, they will need device. So that means palpitation can be very benign, but at the same time could be as a result of a severe life-threatening condition. And so it takes us having a good ability to take a good history, do our examination, and do the important investigation. And like I said, patients with background structural disease, family history of recurrent syncope or sudden death, those with associated symptoms should be sent to the specialist to review. So we reassure where that is necessary. Do your lifestyle modification. Every associated comorbidity should be treated. Then the use of our beta blocker anxiolytic after we have identified what the problem is. And like I said, the use of our mental health colleague is also important. So that's the summary of what I have. Thank you for listening, and we'll take questions. There's a question here. Somebody is.
Thank you, sir, for the wonderful presentation. Please, I would like you to tell us how the Valsalva maneuver, how it's done, and for how long we should do the Valsalva maneuver before. Okay.
So, under Valsalva maneuver, there are many techniques that can be done. One is you can do your carotid sinus massage. That is with your index finger and with your middle finger below the angle of the mandible at the level of the thyroid cartilage. You can just rub for a few seconds, but you should also note patients with carotid artery disease, patients with acute myocardial infarction, you will not want to do that. So you can try it once, twice to see if it's going to work. If it is not working, then you have to do something else. They have other Valsalva maneuvers training. So you can ask the person to take a deep breath. You can pinch the nose, close the mouth, and ask the person to blow. Or if you have a syringe, you can ask somebody to blow into a 10 ml syringe. Then for children, I don't know if it will work for adults. If you get a straw, you can obstruct the straw and tell the patient to blow into the straw. All this is just ways to increase intrathoracic pressure, and that helps to activate the bioreceptor, increase parasympathetic activation to the heart that brings the artery down. Then there's this modified Valsalva that you can do, but I think that's a bit difficult than the normal Valsalva. So by the time you do once or twice, if it's not working, you may need to give your patient drug depending on what you have identified, which is very important. Because if you treat some supraventricular tachycardia and you give some drugs, you convert them to a fatal ventricular tachycardia and you have problems. So identifying what is on the ECG is very, very, very crucial. And not doing anything sometimes may even be better than intervening and causing a bigger problem.
Final question.
Okay, thank you very much. So you said in some cases that we have sudden arrhythmias, the patient might come in and then you send for ECG and then it's fine after the episode. So in such cases, how do you single out that patient when the ECG is fine after the episode?
So that's why I said your history and examination is important. If your history and examination suggests that there may be maybe an underlying cardiac pathology or maybe a possibility of a fatal arrhythmia, and your ECG, your rest ECG is normal, then that patient must do an Holter ECG. That may give you another opportunity of seeing what you are looking for. And that's why I said, as a matter of principle, in the hospital, everybody that is bold enough to come to the hospital to complain of palpitation, we do an Holter ECG to be sure that we're not missing anything. Thank you very much.